good evening, everyone. I'm Olivia. Like Funke said, I am a GP in Surrey. I'm only a newly qualified GP, so I like to think I still am in touch with what life was like at the hospital while I was a GP trainee. Today is the first session of this introduction program to the NHS, or this induction program to the NHS. And what I will aim to do today is to give you a basic overview of what the NHS looks like, what the different organisations that you might, that you might hear of, things like that. So it's a basic overview, it's a basic introduction, and we will do questions at the end. All right, so I'd like to start by saying welcome, and welcome to the NHS. Some of you might be already in the UK in your first job, some of you might be overseas. So it doesn't matter. This is to sort of give you an introduction before you start working. Um, and I think we've already introduced ourselves. The Head Start project was a project we did in 2019, or not 2020, and it sort of tailed off after that. But actually, it was a good idea. I got in touch with Thriving in the NHS, and we thought we'd take it on, restart it, so to say. And why is an introduction to the NHS for international medical graduates important? Because this is what has happened in recent times. The number of IMGs joining the UK has gone up pretty exponentially for various reasons. And the most important reason being that the UK continues to face a shortage of doctors. Um, you probably won't find this in another industry where you have employees from overseas and they come in and they're expected to hit the ground running on day one. But that can sometimes happen in the NHS, where as a doctor you're expected to know the system, know what's happening. So this is just to help ease that transition. In a way, it's to ease that transition to now going to work in the NHS from another system. Taking on feedback from various stakeholders, the sort of the powers that be came up with a standardized induction for IMGs, which is available on the e-learning for health website. That's a website that you will be able to access once you're affiliated to a trust, or once you have an NHS. Yeah. So you'll be able to access this website, and it's a module that you can do, which is a standardized induction. But unfortunately, they haven't publicized this as much as they used to publicize the Welcome in the UK workshop, which I thought is a very good initiative from the GMC. So once you have a permanent GMC registration, they will invite you to a Welcome in the UK practice workshop, and I would recommend that you attend if once you're invited. So that's basically, why we need this induction. We want you to have a smooth transition, between working in your home country and working in the NHS. Now, these are the sessions that we will hope to cover. So today is the overview, and today is basically an overview of, and I'll pick and choose from things. The next session is going to be a day in the life. So, how you document things, how you maintain a jobs list, what might be the various systems that you use, how to make a referral, how to update families, that sort of thing. And what the junior doctor role really is on a day-to-day. Is what we will cover on that session. And the third session will be on communication skills. I'm sure when you've done your PLAB to academy staff, you've probably come across the importance of communication and communication skills. I think it's sort of really hammered in at that point, isn't it? So we will have a session on communication solely, and then we'll do a few specialty specific topics. So for you to know what are the most common things that you will see, and to introduce you to those specialties in the UK context. So we're doing IMT, GP, surgery, psychiatry, pediatrics, obs and gynae, A&E. and then we'll do a session on common procedures, because in our home countries, sometimes nurses don't do, sometimes nurses will do IV cannulas and blood sampling, whereas in the UK you have to do it. Whereas in our home countries, sometimes you might have to administer a drug, but in the UK, nurses will do all the drug administration. So that's what the procedure session is, to get you um, accustomed or to create an awareness of what might be expected of you in the NHS. A gentleman called Nyron Bevan. So he was a founder of the NHS, and he founded the NHS as we know it in 1948. The NHS was conceived to be a system that was free at the point of access. So you can see a doctor, you can go to a hospital if you have a medical emergency, and you will get the help that you need free of charge. So it was quite a revolutionary concept and process at the time. So he's known as the father of the NHS. There was a lovely play at the National Theatre called Nye, I think, which was really, really, I would recommend watching it if you're interested, but he was a Labour politician. Now, that's what the foundation was. There's a lot of negativity about the NHS on a good day. But despite all of that, British people are incredibly proud of and value the NHS very highly. So, British people were asked, what do you value the most? And they've ranked things, so they've ranked the NHS the highest, beyond higher than the royal family. So that's something to say. So you will be working in an organization held in very high esteem. And despite all the news, actually, international, the staff working in the NHS is incredibly diverse. It's not possible to walk down a corridor in an NHS hospital or a GP surgery without bumping into someone from, India, Nigeria, Pakistan, the Philippines, and South Africa, various other countries. So you're a very diverse bunch of people working in the NHS. So how does it all work? Like I said in a previous slide, that actually it's free at the point of access. So who actually pays for the NHS? Who pays our salaries, that sort of thing. So it's all paid. So we all pay for it, basically. So we all pay for it through our taxes. The money goes to the government, who then gives it to the Department of Health, and then it gets sort of whittled down through various organizations, down to the service providers. And so NHS England doesn't exist anymore. It used to. All of the backing of the NHS England is directly absorbed now into the Department of Health and Social Care. CCGs don't exist anymore. The flavour of the season is integrated care systems. So all of this terminology keeps changing, but what stays the same is the people in hospitals, the various hospitals, the GP surgeries providing the care. So this is what it's set up like. So you've got, as you would in any system, you've got primary, secondary, tertiary care, and community health services. Primary care is general practice. Where I work, I've just been working today. And it is set up, there's a contract that primary care signs with the government to say what services they will provide. So they will provide immunization or cervical screening, or look after people's asthma, and they will stay open between 8:30 to 6:30 every day. And yeah, and beyond 6:30, so what happens is once GPs are closed for the day, people can call 111, and there's out of hours GP. So you can see a GP even outside of opening hours. If you call 111 and are triaged to be appropriate to see a GP, those GPs are open until 11 p.m. And overnight, there are visiting GPs. So, for example, if someone is palliative and needs their injectable medication prescribed to them, or if someone is bedbound and needs a home visit overnight, there is a visiting GP overnight, and patients can get access to that by calling 111. On the weekends, you still have these out of hours GPs, which again, you get access to by calling 111. So it's not all over as soon as the GP surgery closes at 6:30. There are other primary care providers who basically provide the out of hours service outside of GP opening hours. There's also community pharmacies. So you can go up to a pharmacy and a trained pharmacist can treat you for 7 common conditions plus for minor conditions. So if you have a tonsillitis or if you have a UTI, you don't necessarily have to see a GP. You can actually get a lot of this care. More controversial, so to say. So dentistry services used to be free until until a few years ago, maybe a decade ago. But that's changed. You now have to pay to access a dentist. There are NHS and non-NHS dentists. And that's a whole nother thing, but dentists make a part of this primary care. And the other good thing about the NHS is that actually, if you have a problem with your eyes, with your vision, you don't necessarily have to go see your GP. You can actually go to an optician, and opticians are on a program called as ACES, and then they can directly be referred from the optician that have optometrists. They can directly be referred to see an ophthalmologist at the hospital, so that the GP doesn't have to necessarily get involved. Older people can see their GP for eye-related problems. They can also come to A&E, but seeing an optician is a very, very good option, and that's again a part of primary care. Secondary care, so I don't have to explain what secondary care is. It's just that in the NHS, in terms of secondary care, acute care trusts are separate from mental health trusts. So you might have a sort of physical health hospital, so to say, and a mental health care trust, which are separate from each other. They do talk to each other to a certain extent, but they're not in the same building. They will be on different sites. Tertiary care, again, just more specialized services. And even if sometimes a service exists in the same hospital, it's not always possible to get that communication easily. So tertiary care, and again, I don't think I have to explain what that is too much. And then community health services. So there are incredible community health services at the moment. There's a concept of hospital at home. Where people who are the idea is that people recover better in their own homes. So a team of nurses, physiotherapists, occupational therapists can go admit people onto a ward while they're still in their own homes, and then give them IV drugs or IV fluids, that sort of thing. Go out to visit the patient every few hours, twice a day, just to keep on top of that care. So they do choose patients very carefully. But then patients can get all of this IV treatment in their own home, so to say. There's district nurses, health visiting service. So there's a very good community health aspect in the NHS as well. So I've gone on about what the various services are, and a patient in a day might actually access all of them. And so this is the case of John, so to say. So John was at home and he had a fall. He hit his head. His wife was there, and who noticed that, and she called an ambulance. So ambulance trusts are also separate to your local NHS trusts. They have their own sort of separate system. So the ambulance came out to him. They decided that he needs to go in. They took him to A&E. He was seen by a junior doctor in A&E. His CT head was normal, but he was found to have fractured his hip. He was treated for this by the orthopedics and the orthogeriatrics teams, and then he was then transferred to a community hospital for a bit of rehab. He had occupational therapy and physiotherapy assessments, who realized that actually the home environment was probably needed more support. He needed more support in the home environment. So they then provided him with a package of care. And this is where the healthcare system sort of integrates or interacts with the care system. So when you discharge patients from hospital, if the support for them at home is not adequate, or if they need care, then we need to think of social care in the form of carers at home, in the form of admissions to nursing or residential care homes. They're not a part of the NHS, but they interact to a good degree by the NHS, and the NHS does discharge patients to nursing and residential homes. However, how access to healthcare is free at the point of access. Access to care, social care, is means tested, which means that you have to prove that you need this So you need to earn below a certain amount, or you need to have savings below a certain amount before you can access social care. So this was, this was John's journey, wasn't it? He saw an ambulance trust, and some patients, I will let you know, is that once they've had a fall and they've injured their head, instead of calling an ambulance, they call their GP because they believe and trust in their GP so much. So in one sort of healthcare episode, a patient might access their GP. They might then be advised to call an ambulance. They'll access an ambulance. They'll go to a hospital, a secondary care hospital. If he had an intracranial bleed, for example, he would have to be then transferred to a tertiary care hospital. And then they get discharged to rehab hospitals, which are sort of more community health, let's say. And then there's that social care. So it's a real integration of various teams that work in the NHS. Right, so there are various teams that work in the healthcare system, but also within the healthcare system, within on a ward in the NHS, you work not just with doctors, you work with a multidisciplinary team, and that to me was a new concept, relatively new concept, let's say. When I was back home, I worked with nurses, doctors, and at most I might work with a dietitian or a physiotherapist on the ward. But NHS is truly, on an everyday basis, you will work as a part of a multidisciplinary team. So if we look at the team on a ward, actually, especially on a sort of say a geriatrics ward, it's not uncommon to have a physiotherapist, an occupational therapist, your junior doctors, your nurses, some advanced nurse practitioners, maybe physicians associates, um, care coordinators. So care coordinators are people who identify the patients who need discharge and then will organize the relevant packages of care for them, or identify if home is a safe place for them to go, or identify if they actually need a residential care home now or a nursing home, and we'll make that happen. And then you have liaison site teams who come in and out as needed. So MDT working is truly, truly MDT working. If you're an oncologist, for example, and you've taken a biopsy or you've organized some scans, even those scans and biopsies are discussed at a cancer care MDT meeting. Right. So yes, literally today I looked after a patient with a melanoma and I looked through his notes, and actually that skin biopsy was discussed at an MDT with dermatologists, oncologists, dermatology specialist nurses, and pathologists. So everything is sort of shared decision making, so to say. So back home, there was a clear hierarchy. So there was doctors at the top of the pyramid, and then sort of other various healthcare professionals. But actually, in the NHS, the hierarchy is very flat. So sort of nurses, physiotherapists, physicians associates, we're all colleagues. We are not their superiors. And reciprocally, they are not your superiors. We are all colleagues working together to provide care. That being said, I would be lying if I didn't say that there wasn't a hierarchy at all. At least in terms of doctors' teams. So if you look at the doctors' teams, it's almost like a pyramid model. So you have junior doctors who are in the very initial stages of their training. So you've got the foundation years 1 and 2, and mostly they will be trainee doctors. But many trusts over the years have now expanded their sort of foundation program to have trust grade foundation doctors. And I was someone who did a trust grade foundation program, and it was such a good program. It was so well done that I just continued to work at that hospital because of how good it was. So foundation doctors can either be trainee or non-trainee, but at the end of the day, all doctors have training needs, whether they're trainee doctors or non-trainee doctors. And then after you sort of you go one rung up, doctors with a bit more experience, doctors who are basic specialty training, so doctors who are doing their IMT, um, doctors who are doing their IMT, their CST, their basic pediatrics training. So there's those doctors. Um, who are there, and this is the group where you have the most number of or a good number of locally employed doctors or IMGs working in trust grade roles. So that's the SHO equivalent, the basic specialist trainee. Some people, and actually that does also include foundation year 2 doctors. And then you have your registrars who are ST4 and above, I want to say. I think it's ST3 and above in certain specialties where you become a registrar. And again, you can have trainee and non-trainee registrars. There's fellows, not as commonly, but there are fellows, and there's consultants. And now you've got, not now, again, there's another very established role called the staff and associate specialist role, which is basically doctors who have a very high skill level, who have worked in the specialty for many, many years, but they've just not gone on to become consultants. So they work as consultants to a certain extent, but they don't have all the responsibilities of a consultant. So those are staff and associate specialist doctors. And over the years, for various reasons, because of staff shortages, etc., we've had allied health professionals who also deliver care in our teams alongside us, and they can work at various levels in this pyramid. So you can have an advanced nurse practitioner, an anesthetics associate, a physician's associate, a first contact practitioner, a paramedic practitioner, an emergency nurse practitioner at either the SHO, the Reg level, and many of them have independent practice. Physicians associates cannot practice, and anesthetics associates as well, I think, cannot practice independently, but other groups can practice independently to various extents, and you might be asked to well, that's a bit more controversial, but get advice on what happens in your local teams, because you might be asked to prescribe for them, you might be asked to request investigations for them. You have to do your due diligence in looking through the notes and assessing whether that request is appropriate before you do the prescribing, because at the end of the day, the person who is prescribing holds the responsibility. But as a junior doctor, you might not be expected to do that. So just find out what happens in your local team, and are you expected to supervise any of the allied health professional roles? I think it's quite an important thing to think. If you join at an SHO level, a few things are expected of you, but at the end of the day, you are very much expected to ask questions and escalate cases further up the ladder, and that's how you go. So an F1 will escalate to an FY2, or an SHO will escalate to a Reg, and a Reg will escalate to a fellow or the consultant. So that's how you go. So you've got and you can always reach out to other team members. So there is a very helpful service in the hospital called the Critical Care Outreach Team. So if there are very ill patients, nurses who have worked on the ITU for many, many years can come out and help the nurses on the ward and help you as a junior doctor or a resident doctor to deal with some very seriously ill patients. So you have a lot of support on hospitals, and I would say make use of all of that support. But additionally, sometimes it's good to think, it's good to say, okay, I know what I'm doing. So it's good to have a few tricks or resources in your pocket. So these are all the apps that I used when I was a junior doctor, and I was very app hooked because I hadn't practiced in India for very long. I was quite a new doctor, and the system in India is very different to working in the UK or even to working in Nigeria, where you're at least in my hospital, you're a very heavily supervised doctor in the beginning. You're only allowed to be independent, maybe a couple of years down the line. So I found the independence a bit challenging, so to say. But these were the apps I used. So MD Calc, gives you a lot of scores. So for example, if you wanted to calculate the DVT well score or the PE well score, or there are lots of interesting scores now called the PERC and the PESI for pulmonary emboli, MD Calc is a very good resource to have on your phone. So you just pull out the app. And then there is the Ask to See Patient, which I thought was an incredible resource if you're an FY2 or an SHO. And what happens is a nurse will bleep you or someone will bleep you and say, "Hi, can you come see this patient? So you've been asked to see a patient." And I used to just pull out my phone, read through it while walking to the patient just to make sure I know what I'm doing once I go there. And then there's the Foundation Year Doctor app, again, which is quite helpful if you're starting out at an SHO or quite a junior level. Microguide is an app which has your local antimicrobial guidelines across all the NHS hospitals. So you'd have to select what hospital you work at, and then Microguide will give you your hospital guidelines. So say someone has cellulitis, for example, so you plug in cellulitis into the app and it will tell you what antibiotics are recommended. It gets so for example, and different hospitals will have different guidelines for neonatal sepsis. In my first hospital, we used to use Ben, Pen, and Gent. In my second hospital, we just used Cefalexin. So there are these differences between hospitals, so it's always good to check on Microguide. From there, I'll swiftly go to BNF. You have to use the BNF for dosing, and BNFC is for children, so you have to use the BNF. With the BNF, there's also the CKS. If you go to the website, you have BNF and CKS and all of that in the same place. But there's also the CKS app, which you can use to just go through guidelines. That's more for primary care, though. Switch is an app that tells you extensions or bleep numbers for various teams in your hospital. Again, very useful because as an A&E SHO, you might be expected to bleep everybody around the hospital. As a medical SHO, you might have to bleep the surgical SHO, gynae SHO, whoever. So that app, which used to be called Induction, is now called AccuRx Switch, I think. Very helpful. iResus is an app that has all your latest resus guidelines in an app. Geeky Medics is actually an OSCE type app, and that will is an OSCE type app, which will tell you how to examine patients, etc. But probably best not to use it at work. But again, it's a helpful resource. BMJ Best Practice has guidelines from the BMJ across multiple health conditions. So these are all the apps. And like I said, when I was a junior doctor, I was very app heavy. I was very happy. And so I would recommend downloading a few of these, give a few of these a go before you start, sort of thing. And I think that is my last slide. So I thought I'd just include, especially given the recent news about the BMA passing a motion for UK-wide prioritizing, oh, whatever that is. There were lots of questions that came up about what the BMA's role is and can they pass a policy and does that become law? So I thought I'd just go through what these different organizations are and which ones you are, recommended to join. So there's two parts to your practice. One is you deal with patients and the other is you deal with an employer. And you need protection while you're dealing with both in a way. So while you're dealing with patients, you need an insurance. So, if you do make a mistake or if something goes out of hand or if you get sued, you are protected by Crown indemnity, so to say, but you need to have your own protection, and that's your Medical Defence Organisation, so MDO. And there are three very popular MDOs in the UK, which is the MPS, so it's on the right side of the screen, so MPS, MDDUS, and the MDS. So there are or MDU, MPS, MDDUS, and MDU. So these are three organizations that, even if you don't have membership of anything else, I would recommend having membership of a indemnity provider. And actually, as a trainee, as GP trainees in my scheme, we used to get MPS paid for. Um, you can claim tax back on some of this, but that's a different, very complex conversation for later. Um, and so that protects you in your interactions with the patients. Now, when you work for the NHS, you need to have a union, or you can choose to have a union, but things do sometimes go wrong in your dealings with your employer. So, if are your pay slips being done correctly? Are you getting all the leave you need? Is there anything going wrong with your mat leave allowance? For example, I was given, sometimes they overpay you and they expect you to pay back uh, it in a lump sum and you might not have the money. So in that case, having a trade union to fight your corner with the trust can be quite helpful. So again, these are all membership-based organizations, and they do sort of fight for doctors' rights, and they will fight for sort of full pay restoration, that sort of thing. And there are various trade unions. The BMA is by far the most popular, the one that has the largest membership. But it by no means is the only one. But there is the Doctors Association UK and the Hospital Doctors Union, or the uh, I don't know what the full form hospital. I don't know what the full form for HCSA is, but these are your other trade unions. And then separate to that, so the BMA can propose policies, can come up with policies it wants to lobby other organizations for, but a law passed by the BMA or a rule passed by the BMA is just a rule to itself. It does not immediately become law. That is all done by the Department of Health and Social Care. This is just a trade union. Then you have the GMC, who you pay your fees to be on the register. You can be reported to the GMC. You can report others to the GMC, although I would not recommend doing that. And again, if something like that happens, then it's good to have a trade union and your medical defense organizations on board. But the GMC is our regulator. It makes sure we're doing all the things we have to do, like appraisals, revalidation, that sort of thing. And then you have your royal colleges, which are in charge of your training in a way, which set out your curriculum and make sure you're following it, and then we'll give you CCTs once you've met the needs of the curriculum. So these are all the various organizations, and now you have the Department of Health and Social Care somewhere there as well. So I think that sort of wraps up what I wanted to share today. Couldn't possibly cover it all, but I've tried. So if you have any questions, uh, yes, please feel free to ask. So I can see a question here that says, you didn't understand what the AccuRx Switch app does. So what the AccuRx Switch app is that it's like a directory. It's a phone directory, so to say. So you find your hospital, and then you find the phone directory for your hospital. So you can directly bleep. So if I have to get if I have to get the orthopedic surgeons to come see one of my patients, I don't have to go searching for the number to bleep the orthopedic surgeons. I get my phone out, I look at this app, and I find their number on this app. You can also go through the operator for your trust, but that just involves you hanging on the phone for a lot longer. So that's the app. It's like a directory for with various extensions and bleep numbers.